Greetings and welcome to join me for a quick catch-up on intersectional approach to gender equity in eye health. This video is one of IAPB's series focusing on gender equity programs. Applying an intersectional approach is key to achieving gender equity because women constitute a very diverse group. In daily life, gender intersects with other identities such as age, culture, disability, ethnicity, race, and geographical location, among others. Therefore, more than one identity should be considered when explaining how and why gender inequities come into being in a particular context. The intersectional approach reflects on the effect of colliding identities which culminate the marginalization and exclusion of certain groups. On the other hand, intersectional lens is vital to responding to gender inequalities resulting from compounding factors. In this video, we will see how gender roles and individuals' place of residence interact and result into a high prevalence of blinding trachoma among rural women. In concluding remarks, programmatic steps to achieving gender equity in eye health with the intersectional approach will be discussed. Welcome again. My name is Mathilde Umuraza. I'm a gender expert at Light for the World International. Light for the World International is a disability and development organization. It is based in Austria and currently actively operates in Burkina Faso, Ethiopia, Kenya, Mozambique, South Sudan, and Uganda. Our areas of interventions focus mainly on disability inclusion, eye health, and neglected tropical diseases. Light for the World International is one of more than 150 organizations which form the International Agency for the Prevention of Blindness. The consortium works and advocates for affordable, accessible, inclusive, and equitable eye health. Addressing gender inequalities has been a central concern for eye health in general and the work of IAPB in particular. For almost a half a century, we have seen increasing evidence that women are affected by blindness and vision impairment to a much greater degree than men. According to a 2020 report by IAPB, 609 million women and girls live with vision loss compared to only 497 million men and boys. This is equivalent to 55%. Overall, women are 8% more likely to be blind, 15% more likely to have moderate to severe vision impairment, 12% more likely to have mild vision loss, and 11% more likely to have near vision impairment. Two major factors have been associated with differentiated eye health outcomes between women and men, namely demographic and gender factors. First, women live on average longer than men. Therefore, they have a greater risk of developing age-related eye conditions. Second, and because of gender norms and roles which are prevalent especially in low and middle-income countries, women have limited or no access to primary eye health services for prevention and screening as well as for further care. It is true that gender inequality is a leading factor in poor eye health among women in general. Yet, and as far as rural women are concerned, gender roles intersect with the area of residence to result in a much higher prevalence of vision loss. That's the reason why it is impossible to address this issue without evaluating multiple intersecting factors. To get it concrete, I will use the example of trachoma. Trachoma is the seventh leading cause of blindness behind uncorrected refractive errors, cataract, age-related macular degeneration, glaucoma, diabetic retinopathy, and corneal opacity. However, among all those causes, trachoma remains the first cause of preventable blindness. Alone, it is responsible for the blindness and vision impairment of about 1.9 million people, and the majority of whom are women. According to a fact sheet on intersectionality developed by Light for the World International earlier this year, the prevalence of trachoma is 1.8 times higher in women as compared to men, and this proportion is estimated to be much higher in rural communities where it may reach up to 3 or 4 times. Epidemiologically, trachoma is caused by ocular chlamydia. This bacterium spreads quickly in poor hygiene settings through human contacts and sharing of dirty clothes. As I already mentioned during my presentation last June, one can acquire the infection irrespective of sex or age. Yet children tend to be more infectious than adults. Due to existing gender roles in many countries which lead women to manage the majority of child care and household work, they are at an increased risk of becoming infected with ocular chlamydia. Another multi-country publication has demonstrated that due to gender roles and subsequent power relations, rural women seek eye services later than men. That it is more likely that they end up losing their vision from the disease. Considering the above, eye health programs and policies, especially those which are trachoma related, should adopt an intersectional approach. Intersectional programs recognize the fact that rural women face an increased risk of chlamydia, infection, trachoma, and blindness. To respond to this, they must include gender mainstreaming at all phases of planning, from policy setting through evaluation. As advised in the Eye Health Toolkit on Gender Equity of IAPB, rural women, their need must be included in the leadership and governance, training of service provider and professional for program against trachoma. Practically, it is important to use a twin-track approach. Some organizations have adjusted their action plans and aligned them to the contextual gender needs. For example, for the activities that require the massive participation of women and men, girls and boys, like community mobilization and early detection, they have used existing community platform. In other cases, community meetings are run during conducive hours of the day or during conducive period of the year, which allow for the greater participation of women. Occasionally, they have also carried out interventions that target exclusively and empower women and girls. Moreover, monitoring gender equity has been proven to effectively reduce the incidence of trachoma among rural women, according to reports from members of IAPB. Learning from above, it can be said that there is no single strategy that can dismantle the barriers and discrimination faced by rural women accessing and benefiting from eye health and trachoma services. Specifically, it implies rather a combination of strategies which are devised and worked out together using intersectional approach based on the context and needs. To conclude, gender intersectional programming in eye health should be: first, contextual and knowledge-based; second, action-oriented; third, regularly monitored; fourth and lastly, they should always be able to adjust it to respond to intersectional experience of women. I thank you very much. Do not hesitate to send us your comment, feedback, and questions. For more detail on the topic and many more, feel free to visit the website of IAPB and Light for the World International respectively. I hope to meet you next time, and bye for now.